If you are a retiree living in Florida, you have probably been tuning in to the chatter, those growing anxieties about the significant Medicare changes barreling toward us in 2026. This isn't just, the routine annual fine-tuning. What started as whispers has officially become a very loud, very real economic reality, specifically for the millions of seniors who call the Sunshine State home.
That's absolutely correct. What we are witnessing is the convergence of necessary federal policy shifts driven by the need to control long-term healthcare spending with the unique challenges of serving Florida's massive, concentrated, and highly dependent senior population.
Right.
And these policy changes are now translating directly into budget pressure, access uncertainty, and, well, a lot of stress for the individual enrolled.
And let's unpack this. We've synthesized a comprehensive stack of source materials, from regulatory filings to actuarial reports that lay out exactly how everything, from your monthly fixed premiums to the specific doctors you can see, is about to shift when the calendar flips to January 1st.
And for you, the listener, who we know is the learner,
Exactly.
me seeking that rapid, thorough, and most importantly, actionable knowledge, this deep dive is crucial. Our mission today is to cut through the bureaucratic jargon and give you a clear roadmap.
Because these are not just minor adjustments to your copay schedule.
Not at all. The financial and structural changes coming in 2026 demand immediate attention for both daily healthcare access and, critically, your long-term financial stability. If you are a Florida retiree relying on a fixed income, understanding these shifts now means the difference between maintaining your current lifestyle and, potentially facing a serious budget crisis just to maintain your current level of care.
We're going to jump right into the financial impacts because that is the most immediate point of stress for anyone on a fixed income. We structured this as Section 1. The initial sticker shock key premium increases, and we have to start with the cost that affects virtually every single retiree, Medicare Part B.
When we talk about Part B, we're talking about the core outpatient coverage, doctor visits, laboratory services, diagnostic imaging, preventative care.
That's the foundation.
It is the absolute non-negotiable foundation of medical coverage outside of a hospital. And the premium jump we are seeing here is not only substantial, but also it reveals these underlying inflationary pressures in the system.
The core detail we pulled from the sources is clear. Starting January 4, 2026, the standard Medicare Part B premium increases by $17.90. That takes the monthly total up to $202.90 per month. That's a fixed cost that immediately hits everyone receiving Social Security.
And to put that $17.90 increase into perspective, we really need to look at the percentage.
Right.
This represents a nearly 10% jump year over year in one of the most essential healthcare costs for a retiree. And here's the technical context the learner needs. This jump is largely driven by projected growth in physician payments and, more critically, the need to shore up the Part B trust fund reserves,
which are under pressure.
They're subject to annual reviews based on projected use and expense. So when physician payment projections run hot, the premium follows suit.
That context is vital. When you are dealing with a fixed income, which is the reality for the vast majority of Florida retirees, a 10% jump in a core monthly expense like this really constricts the budget.
It really does.
Especially when you factor in that this increase compounds year after year.
It creates an immediate erosion of purchasing power. Consider the average cost of living adjustments, the COLA for Social Security recipients. Those adjustments, which are tied to a specific inflation index, have often lagged significantly behind the actual pace of healthcare inflation. A 10% hike in Part B alone means that a significant portion, if not all, of any COLA increase they may have received for 2026 is immediately swallowed up.
Just by this one thing.
Just by this single fixed expense.
Yeah.
So retirees are forced to look for savings elsewhere. Groceries, housing, maybe discretionary travel.
So the Part B increase doesn't just represent a cost. It's a powerful indicator that healthcare cost inflation is running far hotter than general inflation. It sets a really difficult financial tone for the entire year.
Precisely. And remember, this $202.90 is the baseline.
Right. This is just the starting point.
This is only the beginning of the cost conversation, which leads us directly into the complexity of the high earner surcharges, which affect a surprisingly large number of Florida residents. Hashtag 1.2, the high earner surcharge trap, IMAA.
And here's where it gets really intricate for a substantial and often highly prepared segment of Florida's retiree population. We're talking about the income-related monthly adjustment amount, or IRMA.
IRMA.
It's a mechanism many people don't fully understand until it hits them.
This is the high earner surcharge trap, and it's a critical piece of the puzzle because it often catches people who consider themselves financially stable completely by surprise.
Why is that?
The key complexity is the 2-year look-back rule. The premium you pay in 2026 is determined by your 2024 tax return, specifically your modified adjusted gross income, or MEGI.
That 2-year delay is such a tricky concept. It's hard to predict and plan for a cost based on income you earned so long ago. Can you give us an analogy?
Certainly. Think of it like being given a ticket for a tax violation based on a surveillance camera photo taken 2 years ago. The income you earned in 2024, maybe a large Roth conversion, a big real estate sale, or a significant capital gain. That's the photo dictating the premium you have to pay for all of 2026.
So the planning window is always in the past.
Always. It makes active income management so important.
Let's lay out the specific thresholds we found, because crossing this line transforms that Part B cost dramatically.
Absolutely. While the income thresholds themselves have gone up slightly with inflation, the surcharges have also increased. For single filers, the surcharges kick in if your adjusted gross income reaches $109,000.
And for joint filers.
For joint filers, that trigger point is $218,000.
And this is where we need to quantify the financial risk.
Right.
Let's say you're a single filer. Your MEGI lands at $108,000. You pay the standard $202.90.
Right.
But if your NGI hits, say, $110,000, you jump into that first IRMAA tier. What does that cost difference look like?
The jump is staggering. If your income crosses that $109,000 line, you are immediately facing that first IRMAA tier premium. Instead of paying the standard $202.90 per month, you are now likely paying in the realm of $283 a month for Part B.
Wow.
So that small $2,000 income difference in 2024 results in paying an additional $80 per month, or over $960 extra per year, just for Part B.
And we have to emphasize this higher premium applies not just to Part B, but also to your Part D prescription drug coverage.
Right.
So you're often double hit.
That's the subtlety of IRMAA. It affects both core Medicare programs. For Florida retirees, many of whom have significant appreciated assets, rental properties, or are actively navigating complex drawdown strategies from their IRAs or 401ks, planning their retirement withdrawals becomes paramount.
You could have a one-time spike.
Exactly. A one-time spike in 2024 income could lead to 2 full years of significantly elevated Medicare premiums in 2026 and 2027. This isn't just a cost, it's a tax consequence masquerading as a healthcare premium. It requires careful, specialized tax planning in retirement.
The implication, then, is that sophisticated retirement planning isn't just about minimizing your tax bill. It's intrinsically about managing your baseline healthcare costs, which are arguably the most unpredictable and largest expense in later life. Hashtag tag 1.3. Dramatic Part A cost spikes.
Now let's turn to Part A. For most people who have worked 40 quarters or 10 years and paid Medicare taxes, there is no Part A premium.
This is your hospital coverage.
Right. Hospital stays, skilled nursing, hospice care. But for the smaller yet critical segment of the population who did not meet that work history, the premium increases for Part A are truly dramatic. They expose a major vulnerability in their retirement model.
We're talking about an annual expense that can suddenly approach $7,000. Let's focus on those specific jumps we detailed in the sources.
The numbers are indeed eye-opening. For individuals with some work history but less than 30 quarters, the reduced premium rate is rising to $311 per month.
Okay.
And the full premium for those with less than 7.5 years of work history is spiking up to $565 monthly.
$565 a month, just for hospital coverage. That works out to $6,780 a year.
It's a massive non-discretionary hit.
What specific population in Florida needs to be most concerned about this? Who are we talking about here?
Well, we see 3 primary groups affected. First, late career immigrants who may have come to the U.S. later in life and didn't accrue the full 40 quarters. Second, individuals who took early retirement or had long periods out of the workforce.
Right.
And third, certain government employees who are part of alternative retirement systems and didn't pay into Medicare. For these individuals, $7,000 a year is not a small line item. It is a major budgetary concern, potentially representing a quarter of a modest Social Security income.
So the relevance here is that these massive premium increases must be immediately modeled into any carefully crafted retirement investment strategy.
It has to be.
If you know you fall into this category, this fixed high cost will severely restrict other aspects of your budget, making cash flow planning incredibly tight.
It completely changes the financial gravity of their retirement. It underscores the necessity of having that comprehensive financial strategy because Part A costs can shift from being a forgotten benefit to being a budgetary disaster overnight for those who rely heavily on Medicare but don't have that 40-quarter benefit.
That analysis perfectly sets the stage for the next layer of complexity. We've covered the fixed financial shift in original Medicare. Now, shifting from fixed costs to the highly unstable world of private plans, let's look at why your Medicare Advantage coverage might suddenly feel like it's shaking apart. This brings us to Section 2, the Medicare Advantage plan shakeup in the Sunshine State.
This section is especially critical for Florida because Medicare Advantage plans, often sold as zero premium options with these enticing supplemental benefits, are incredibly popular among the senior population here.
It's hugely popular.
Florida has one of the highest MA enrollment rates in the country. But the stability of these plans is now fundamentally in question due to federal regulatory changes. Hashtag 2.1, turbulence and disappearing plans.
We're seeing a lot of turbulence, and it all boils down to how the federal government chooses to pay private insurers. What is the fundamental cause driving this 2026 shakeup?
The cause is the changing federal reimbursement formulas, coupled with adjustments to risk adjustment models. The government adjusts how much it pays private insurers per enrollee. It's known as the capitation rate, based on the predicted health of the covered population.
Okay.
For 2026, the rate structure adjustments are designed to refine risk scoring and tighten up payment methodologies. When the insurer receives less federal revenue per member, they have to compensate.
And the effect of this squeeze is just brutal for the consumer, who suddenly finds their trusted healthcare structure collapsing.
It leads to 3 immediate consequences, all of which mean mass disruption for the retiree. 1, some Medicare Advantage plans are disappearing entirely because they're no longer financially viable for the insurer.
Just gone.
2, surviving plans are dramatically hiking premiums, which eliminates that zero premium appeal. And 3, still others are significantly slashing benefits, often those highly valued supplemental benefits. Retirees who thought they had a stable healthcare structure locked down are being forced back into the enrollment market.
The emotional trauma of losing a plan you were happy with, especially if you have complex long-term health needs, cannot be overstated. It just introduces a massive amount of planning uncertainty into a life phase that craves predictability. Hashtag 2.2, the star ratings impact.
And that trauma is heavily influenced by the federal star rating system, which functions as a major high-stakes mechanism influencing plan viability. This system rates plans from 1 to 5 stars on dozens of quality metrics.
Things like preventative care, patient outcomes.
Right, and member satisfaction, all of that.
So how do those stars translate into real-world stability? Why should the average retiree care about a plan's star rating?
It's a direct, multi-million-dollar financial incentive. Plans that achieve 4 or 5 stars receive substantial additional federal funding. They're known as bonus payments, which makes them much more likely to survive, thrive, and, crucially, maintain richer supplemental benefits.
Like those $0 gym memberships or robust dental coverage?
Exactly. These bonus payments are what fund those extras.
Conversely, the risk is concentrated in the plans that fail to achieve that threshold.
Precisely. Lower-rated plans, those below 4 stars, receive no bonus payments. They are often the first to be eliminated entirely or forced to make drastic benefit cuts to compensate for the lack of federal funding.
So here's the crucial insight for the learner.
Yes. You might lose a plan you were perfectly happy with, not because of your satisfaction, but simply because the plan's overall infrastructure failed to score high enough on these federal quality measures. It introduces a layer of systemic instability that retirees have to monitor annually, regardless of how they feel about their own plan.
That makes the star rating a critical risk factor that needs to be calculated every single enrollment season.
Yeah.
It's not just a consumer guide. It's a predictive tool for plan stability.
Yeah.
Hashtag 2.3, network changes and access problems.
And this systemic instability immediately funnels into arguably the biggest real-world concern when a plan changes: network instability.
Right.
We are talking about doctors and specialists being dropped from networks or entire clinic groups pulling out of contracts in 2026.
This is the crisis point. MA plans are typically managed care HMOs or PPOs, meaning they rely on a specific contracted network of providers. When a plan shrinks or an insurer pulls out of a service area, the network automatically shrinks, forcing the retiree to potentially lose years of established relationships.
And this problem is compounded heavily by the specific geography we are focusing on: Florida. Florida has a disproportionately massive senior population, putting extreme pressure on the healthcare system. And many coastal and rural areas already suffer from ongoing physician shortages. So if your doctor is dropped, finding a suitable replacement quickly, especially a specialist accepting new Medicare Advantage patients, is incredibly difficult.
It's an access problem built on demographic strain and managed care contracts.
It is.
When a doctor is dropped, the retiree faces those two distinctly bad options we identified in our source review. Let's detail the real cost of those options.
The tough choices are stark. Option 1, find a new doctor within the network. This means abandoning an established, trust-based relationship, which often disrupts continuity of care.
I mean, imagine.
Imagine a client we had managing advanced cancer whose longtime oncologist was dropped mid-treatment. That shift from a clinical crisis to a financial one, or worse, a trust crisis with a new provider, is incredibly taxing and can lead to poorer health outcomes.
And option 2, which seems financially ruinous for many MA users.
Option 2 is to pay significantly higher out-of-network costs to retain their preferred provider. And this completely defeats the purpose of the lower premiums you sought in an MA plan in the first place.
Right.
If you're paying original Medicare costs for that service, you are now responsible for the Part B deductible and the standard 20% Medicare copayment, which can be thousands of dollars for complex procedures. In a managed care environment, going out of network is a fast track to massive unexpected bills that can easily exhaust any retirement savings padding.
So the MA turmoil essentially forces a trade-off between the stability of your health relationship, that continuity of care, and your financial predictability.
A trade-off that is unacceptable, especially for serious or ongoing medical conditions. The stability of the provider network should be the #1 factor retirees check during the open enrollment period. If you can't see the doctor you trust, the plan's cost savings are irrelevant.
The turbulence in MA plans leads directly into our third section, which focuses on those day-to-day costs and the previously attractive supplemental benefits that are now under pressure. Out-of-pocket costs and benefit cuts on the horizon.
We need to set the expectation clearly. Despite some isolated reports of maximum out-of-pocket limits slightly decreasing in certain high-performing plans, the overall trend for most Florida seniors is to prepare for higher actual out-of-pocket spending in 2026.
The way they pay for services is shifting.
It is.
Let's talk about the insidious nature of copay spikes. These are the small costs that often get overlooked in the glossy benefits brochure that hit hardest during routine care. They're the silent budget killers.
They absolutely are. Our sources indicated that co-payments for common services are expected to rise across many plans, often significantly. We're talking about a typical $20 primary care doctor's visit copay potentially jumping to $30 or even $40.
That's a 50% to 100% increase on a routine essential expense. So what's the real-world implication of that on a retiree's actual healthcare use, especially for those already watching their pennies?
The implication is massive, particularly for those managing multiple chronic conditions, which is common in the senior population. Someone with comorbidities like diabetes, heart failure, and hypertension might see several specialists throughout the year.
Right.
If every visit costs an extra $10 or $20, those small individual increases add up quickly, easily, hundreds of dollars a year. But the more dangerous outcome is the psychological deterrent.
They might put off a visit.
These hikes can dissuade retirees from seeking necessary care. They delay an appointment to save $20, which then leads to a hospitalization for an acute complication that costs the system and the patient thousands.
It shifts the financial burden subtly and consistently from the insurer to the patient, visit by visit, creating a disincentive for preventative health management.
Exactly. And the out-of-pocket maximums are also under pressure. While an insurer might advertise a slightly lower maximum limit, if they dramatically increase the copays and deductibles before you reach that limit, the retiree ends up paying more frequently and earlier in the year. The reality of the overall cost burden is rising, even if the theoretical cap looks okay. Hashtag 3.2. Trimming the supplemental extras.
Moving on to the attractive elements of MA plans, if copays are the silent budget killers, the trimming of supplemental extras is the benefit sacrifice insurers are making to stay financially viable.
These supplemental benefits, dental, vision, hearing aids, gym memberships, transportation, were the key selling points that made MA plans so appealing in the first place.
They offered that added value beyond original Medicare.
Exactly. Now, facing cost pressures, insurers trim these first because they are generally considered non-essential medical services.
And it's those highly desirable services that are the specific targets for cuts.
That's right. The specific targets for cuts are often dental coverage. especially comprehensive care, vision care, hearing aid allowances, gym memberships like Silver Sneakers, and transportation services.
And for a low-income retiree, the loss of transportation assistance can be a huge barrier to care.
A huge barrier. Likewise, losing the allowance for hearing aids, which can cost thousands, or losing comprehensive dental coverage, which prevents serious infection, is a significant blow to quality of life and preventative wellness.
We should note the specific exception our sources highlighted regarding stability in the Florida market, which really underscores the importance of plan selection.
Yes, this is an important counterpoint to the general trend. It was specifically noted that major players like Florida Blue Medicare continue to offer comprehensive benefits across all 67 counties.
So some are holding the line.
It suggests that while general cuts are widespread, vital plan comparisons are necessary. Some major carriers are making the strategic decision to maintain these valuable benefits, while others are making deep cuts to stay afloat. The comparison shopping for 2026 is vital to ensure you don't lose that gym membership you rely on. Hashtag 3.3. Prescription drug formulary updates.
Shifting to medications, this is another area where small print changes can cost hundreds or thousands of dollars annually. We're talking about the prescription drug formulary updates.
This is a complex area because every Medicare Advantage plan maintains its own specific list of covered medications, its formulary, and dictates what cost tier they fall into. Tier changes are how the insurer manages cost on the micro level, regardless of national policy.
And the risk for the retiree is significant and immediate, hitting the wallet month after month.
The risk is substantial. There is a strong chance that current, long-standing prescriptions might move to a higher cost tier or disappear from coverage entirely.
So a generic could suddenly cost more.
A common generic drug moving from Tier 1, which is a minimal cost, to Tier 2, a moderate copay, can double or triple the monthly cost instantly. And a brand-name specialty drug moving from Tier 3 to Tier 4 could mean going from a $50 copay to a 25% coinsurance, costing the retiree hundreds more annually for the exact same medications.
This necessitates an immediate and meticulous review of the 2026 formulary against your personal list of medications.
It is the most mandatory action step in the entire enrollment process. If you have 5 maintenance medications, you must verify the coverage and cost tier for all 5. Ignoring this check is ignoring your financial security for the entire year.
So if we step back, what is this accumulation of financial risk? The Part B hike, the IRMAA trap, the rising copays, the benefit cuts. What does it all mean for the big picture of retirement planning for the learner?
It means comprehensive estate and retirement planning is not optional. It's mandatory survival preparation. Healthcare cost inflation is unequivocally the biggest wild card in retirement planning. These unpredictable shifts highlight the necessity of building substantial financial padding into your long-term budget just to cover this escalation. Ignoring these cost changes is effectively ignoring the financial stability of your future.
That analysis transitions perfectly in Section 4, where we explore the national changes to Part D prescription drug updates, attempting to balance the good news with the micro-level bad news.
While the individual Medicare Advantage plans are causing a lot of this operational turmoil, the structure of Medicare Part D itself is undergoing national legislative changes that contain some genuine, significant silver linings for consumers, particularly those with very high drug costs.
Let's start with the undeniably good news resulting from the Inflation Reduction Act, the Drug Price Negotiation Program.
This is a landmark change with a slow but steady impact. Medicare's new ability to negotiate prices means that 10 specific high-cost medications, often those specialty or biologic drugs used for complex chronic conditions, will be available at lower prices starting in 2026.
So it's not universal relief for every drug.
Not at all. But for users of those specific, very expensive drugs, it could lead to significant annual savings.
And these savings are critical because previously retirees taking these specialty medications could face truly catastrophic costs, even with insurance.
That leads directly to the next point, catastrophic protection. The overall structure of Part D is becoming significantly more consumer-friendly and protective. Critically, the catastrophic coverage threshold is adjusting to provide better protection against those extremely high, out-of-pocket drug costs.
Can you elaborate on the structure improvement? This is a key change.
Historically, once you hit the catastrophic phase of coverage, the plan still required you to pay a small percentage, usually 5% of the cost of the drug indefinitely.
Right, there was no true cap.
The structural changes in 2026 are designed to eliminate that 5% liability entirely once you hit the catastrophic cap. This provides a true, finite shield. Once you hit the cap, your drug costs drop to zero for the rest of the year.
That's huge.
And the Part D out-of-pocket cost cap continues to be indexed for inflation, which helps keep the overall maximum spending within predictable bounds year over year.
So on a national macro level, the system is fundamentally getting safer for the consumer, particularly the high utilizer, who depends on expensive medications.
That is the right framing. The safety net is stronger and finally has a true ceiling.
Wait a minute, though. If Medicare is only negotiating prices for 10 drugs, doesn't that just mean insurance plans will raise costs or shift the remaining 100 high-cost drugs to higher tiers to compensate? Is this really a net positive for the average person or just a small subset?
That's a critical and skeptical question the learner needs to ask, and it connects directly to our next point. Yes, the risk of cost shifting is real.
Insurers have to maintain profitability.
Absolutely. So while the catastrophic cap protects the high-cost user, a person taking a mid-tier chronic medication that isn't one of the 10 negotiated drugs could absolutely see their monthly copays increase as the plan tries to recoup projected losses.
So the macro policy improvement is laudable.
But the individual's experience may still be one of rising monthly costs, hashtag 4.2, the individual plan pitfall.
And that brings us to the individual plan pitfall. Despite the overall program improvements, the challenge lies in the micro-level behavior of individual Part D plans, whether they are standalone or part of an MA package.
That's right. Individual plans are actively managing their formularies and risk exposure. They have very sophisticated mechanisms to influence patient behavior and cost profiles.
Which means we are back to the tier changes and potential coverage restrictions, even with national structural improvements.
Exactly. Even if the maximum cost cap improves nationally, your monthly out-of-pocket costs can be seriously affected if your essential medications shift between cost tiers. Plans might impose new requirements like prior authorization, requiring you to get approval before filling a medication, or step therapy, requiring you to try a cheaper drug first.
Which can be less effective.
Right. This manipulation can negate the benefit of the overall structural improvements. If your essential daily medication jumps from $20 a month to $100 a month because the plan moved it to a higher tier, you still feel that pain every month, even if the theoretical catastrophic coverage is better.
So the message to the listener is, don't assume the national improvements save you money. They only strengthen the safety net. You must still check your specific plan's formulary against your personal list of medications.
It is an absolute mandatory action. The generalized good news does not apply if your individual plan has silently shifted your drug costs upward.
To balance out the picture of financial stress and instability, let's move on to Section 5, which highlights some genuinely positive expansions in covered medical services for 2026.
It's important to take a moment and recognize that not all changes are reductions in coverage or increases in cost. Medicare is strategically expanding coverage in key preventative and management areas for 2026, which represents an investment in long-term health outcomes. Hashtag 5.1, colorectal cancer screenings.
The first piece of genuinely good news is the new full coverage for colorectal cancer screenings.
This is highly significant because these screenings are now fully covered, removing cost barriers entirely. Historically, patients might have faced unexpected copays or cost sharing for procedures like colonoscopies.
Right, based on technicalities.
Exactly. That uncertainty is now removed. This falls into the category of life-saving, evidence-based preventative care.
And the relevance of this for the Florida demographic is particularly high, given the state's concentration of older adults.
Given Florida's aging population, early detection of colorectal cancer is critically relevant. When cost barriers are removed, utilization typically increases dramatically.
And early detection saves lives.
It means dramatically better survival rates and, crucially, less intensive and less expensive treatment down the line. If a full colonoscopy costs the system $1,500 now, but prevents a $100,000 surgical intervention later, it's a strategic investment in the health of the Medicare population and a win for the taxpayer.
This is the kind of change that saves both lives and money in the long run by shifting focus from treatment to prevention. Hashtag 5.2. Advanced Primary Care Management, APCM.
Another important addition is the enhanced coverage for Advanced Primary Care Management Services, APCM. This is a subtle but profound structural improvement.
What exactly does APCM entail, and why is this model a beneficial addition for managing chronic conditions?
APCM represents a strategic shift toward highly coordinated proactive care. It moves away from the traditional episodic fee-for-service visits where a patient only sees the doctor when they are actively sick. Instead, APCM is designed to provide comprehensive ongoing management especially for patients with multiple chronic conditions. It facilitates deeper communication, data sharing, and care coordination between the primary care doctor, specialists, nutritionists, and care managers.
So the benefit isn't just one service, but a coordinated system designed to surround the complex patient.
Precisely. This type of coordinated, holistic care helps manage chronic conditions far more effectively by focusing on preventative measures, proactive monitoring, medication adherence. It can potentially prevent those costly acute complications down the road, like unnecessary ER visits or hospital readmissions.
This is Medicare focusing on the complex patient to improve outcomes and contain costs by keeping people healthier longer.
It is.
These two expansions, full screening coverage and coordinated care, are definite positives that the listeners should be aware of when they evaluate their overall 2026 coverage landscape. It shows that even amidst the turbulence, the system is attempting to evolve positively.
They absolutely are. They show a commitment to improved long-term health outcomes despite the market pressures.
That moves us to the most practical and crucial segment of this deep dive, Section 6, which focuses on the actionable steps and enrollment options moving forward. If you've listened this far, this is the checklist you need to execute immediately.
For the learner, this is the payoff. We've described the problem, now we provide the solutions and the crucial timing windows you must respect. Hashtag 6.1, the post-enrollment window, the January 1st, March 31 lifeline.
Let's clarify the timing. The annual enrollment period, that standard window where most people make their changes, already ended on December 7, 2025. You are already locked into your 2026 plan.
Correct. But many retirees are only now finding out the true gravity of their 2026 changes. Their official annual notice of change, or ANOC, documents arrived, and the reality of the premium hike or the network loss is sinking in as they try to book their first 2026 appointment.
Fortunately, there's a crucial lifeline available, designed specifically for course correction.
That lifeline is the Medicare Advantage Open Enrollment Period, which runs from January 1st through March 31st, 2026. This 3-month window is designed specifically to mitigate buyers' remorse or sudden catastrophic instability in their chosen plan.
And what flexibility does this window afford the retiree? This is the one chance for a do-over.
They can make one plan change during this 3-month period. This is crucial if they start using their 2026 plan and realize the changes are far worse than the summary documents suggested.
So they can switch from one MA plan to another MA plan.
Or they can drop their MA plan entirely and return to original Medicare.
And what happens if they miss that March 31st deadline?
If you miss the March 31st deadline and you don't qualify for a special enrollment period, you are locked into your current plan for the rest of 2026, regardless of how much you dislike the new costs or network restrictions. This 3-month window is a vital safety valve. Hashtag 6.2. Special enrollment periods, SEP.
Beyond that standardized January to March window, there are special enrollment periods, or SEPs, that offer flexibility in specific circumstances.
SEPs provide additional flexibility if a major qualifying life event occurs outside the standard windows. The most common reasons related to the MA turmoil we've discussed are if their current Medicare Advantage plan is ending entirely. The plan is being discontinued, not just revised, or if the retiree is moving to a new area in Florida that is outside of their current plan's service area.
So specific situations.
Right. These periods allow for changes outside the usual defined windows, but the qualifying event must be severe and documented. Hashtag 6.3, considering the original Medicare Medigap option.
Given the increasing turbulence and unpredictability in the Medicare Advantage landscape, with plans changing year over year, many people might be wondering if it's time to step off that MA roller coaster entirely and seek stability.
That is always an important consideration. Retirees always have the option to return to original Medicare Parts A and B. This choice involves a different cost structure, but offers the crucial benefit of stability and national, predictable access.
Let's contrast that cost structure with MA plans. Why would someone choose Medigap, despite the higher fixed monthly cost?
While complementing original Medicare with a Medigap plan typically involves a higher monthly premium than a zero-premium MA plan, it offers two overwhelming advantages for those who prioritize security. First, more predictable costs, because Medigap plans standardize the coverage of that 20% Medicare copay.
Minimizing out-of-pocket exposure.
Exactly. And second, significantly broader provider access, because Medigap plans are accepted by any doctor nationwide who accepts original Medicare, eliminating those troublesome state-specific MA network constraints.
So the trade-off is Higher fixed monthly premium, but lower exposure to out-of-pocket costs and maximum access.
Exactly. It's paying more for predictability and choice. However, and this is a critical warning, if they drop MA and want to switch to Medigap outside of their initial eligibility window, they may be subject to medical underwriting in Florida.
Meaning they could be denied?
They could be denied coverage or face higher premiums for a Medigap plan if they have pre-existing conditions. So the return path can be dangerous if they wait too long.
And if they choose original Medicare and Medigap, they need one more component to complete their coverage package.
Absolutely. They must add a standalone Part D prescription drug plan. That prescription coverage is separate from Medigap, so it must be purchased separately to complete the package. This is the path of stability, choice, and predictability, but it requires a higher monthly outlay. Hashtag 6.4. Mandatory action steps for the listener.
We've broken down the financials, the MA volatility, and the crucial options. Now let's wrap this section with the 4 mandatory action steps the listener needs to take right now, leveraging that January 1, March 31 open enrollment period.
This is the essential practical checklist for everyone listening.
Action step 1. Review changes, not summaries.
Look carefully at the annual notice of change materials from your current Medicare Advantage plan. Do not trust the summary brochure. Pay special attention to the doctor network status, the formulary changes for your specific prescriptions, and any explicit reductions in supplemental benefits. Scrutinize the fine print.
Action step 2. Contact providers.
This is the critical access check. Confirm with your primary care doctor and your specialist that they remain contracted with your plan for 2026. Do not assume. Call their office directly and ask for the person who handles insurance verification, and research alternatives if they are dropped. Do this before you need critical care in the new year.
Action step 3. Evaluate medications against the formulary.
You must check if your medications are still covered at the same cost tier. Use your plan's website tool to verify this. This is where you identify if your drug has been quietly moved to a higher cost tier or now requires prior authorization. If you find high-cost surprises, you must compare costs across different Part D plans during that January 1, March 31 window.
Action step 4. Update the budget immediately.
And this brings us full circle to Section 1. You must factor the fixed premium increases, the Part B hike, the Part A spike if applicable, and any potential IRMAA surcharges alongside potential copay changes into your 2026 financial budget. Healthcare is a growing expense that must be accounted for before you spend elsewhere.
That is a highly practical and actionable 4-point plan for navigating this period of intense change. Hashtag outro.
To recap the entirety of this deep dive, Florida retirees are facing a difficult and expensive convergence of rising fixed premiums, that nearly 10% Part B hike, and severe turbulence in the Medicare Advantage market.
Right? Driven by those federal funding changes.
The result is financial uncertainty and genuine questions about access to preferred doctors.
But the core message is that while these changes create inevitable challenges, staying informed and highly proactive is the only way to successfully navigate them. You have that critical open enrollment lifeline from January 1st to March 31st. Healthcare access and costs are just too important to leave to chance or assumption. Take those mandatory steps now.
And if we connect this entire discussion to the bigger picture, the turbulence and rising costs we've detailed lead us to one final essential insight that every retiree and every financial planner advising them must internalize for the next few decades.
What stands out to you as the ultimate long-term takeaway from these 2026 shifts?
The critical insight is the established, persistent, and accelerating trend. Healthcare inflation is definitively outpacing general consumer price inflation. Therefore, the necessity is to continually build in a higher expected healthcare cost growth rate than the general inflation rate into all long-term financial and wealth management planning.
So if your model assumes 3% general inflation,
your healthcare expenses need to be modeled at 5%, 6%, or even higher year after year. Failing to plan for healthcare cost escalation as its own category, separate from housing or groceries, is the single biggest risk to sustaining a comfortable and secure retirement. That is the long-term financial knowledge you need to walk away with today.
That is the essential knowledge for the learner to mull over and apply immediately. Thank you for guiding us through these complex and crucial changes for 2026.